commend the authors, Dr. Rao et al., on their manuscript entitled The Affordable Care Act, a Primer for Plastic Surgeons. The authors distill the essence of the Affordable Care Act and provide a concise summary for plastic surgeons. They discuss some of the problems leading to the passage of the Affordable Care Act, such as the number of uninsured, increasing healthcare costs, and the basis for much of the increased costs associated with healthcare delivery. In addition, the authors mention the increasing prevalence and role of accountable care organizations, known as ACOs, as well as the concept of bundled payments, both of which are now a reality and likely to change the way healthcare is delivered. However, where the authors fall short in their analysis of the ACA is in their extrapolation as to how the ACA will affect plastic surgery practices, whether independent, employed, or academic. Let me try to address some of these issues. While ASPS supports quality initiatives, it is imperative that these initiatives be developed by the individual specialties. What is relevant in plastic surgery, for example, may not be relevant for primary care, and vice versa. As plastic surgeons, we're considered to be innovators, and this is not just in the clinical arena. We're fortunate to have leaders like Andrea Pusick, who, with her team, developed a validated instrument for measuring patient-reported outcome measures known as BreastQ. It's instruments like these that will likely offer validated, quantitative measurements of what has traditionally been very subjective patient satisfaction. Additionally, recognizing the importance of quality parameters, ASPS developed TOPS, tracking outcomes in plastic surgery, in order to assist the membership with tracking relevant quality indices. Again, this is a metric currently used by many breast centers when seeking national accreditation. However, there are also increased regulatory and administrative burdens imposed by the ACA and not addressed by the authors. These increased burdens often result in increased costs and often increased frustration on the part of the practicing physician. I think it's safe to extrapolate that the result of this will be an increased number and percent of employed physicians, and this is statistics that are already borne out by the American Society of Plastic Surgeons. It's also likely that we will see an increasing role of mid-level providers such as physician assistants and nurse practitioners. How mid-levels will be integrated is still a work in progress, but assisting with much of the hospital responsibilities such as emergency room call coverage and wound care may be a good place to start. Many of the regulatory and administrative burdens are already affecting plastic surgeons on a day-to-day basis. For example, it is with great expense that electronic medical records have been implemented in individual physician offices. However, there are significant limitations in the ability of these EMRs to interact with hospital electronic records. This interoperability, or current lack thereof, has added additional hurdles in what is already an increasingly complex administrative environment. Furthermore, there are aspects of the Affordable Care Act which are not necessarily beneficial to patients, and important areas of healthcare reform which were conspicuously left out of the Affordable Care Act. First and foremost, the ACA, whether directly or indirectly, intentionally or unintentionally, has insinuated itself in the doctor-patient relationships. Physicians are under increasing restraints and scrutiny in terms of compliance with perceived quality measures, many of which at this time may not be based on evidence-based criteria. Furthermore, the IPAB, the Independent Payment Advisory Board, a board of non-elected government officials whose role is to recommend Medicare cuts when spending exceeds the targeted growth rate, is also opposed by many specialty societies. Finally, the failure to address medical liability reform is a glaring problem with the Affordable Care Act. What would seem to be important in controlling costs and improving quality of care is competition. Whether a result of the Affordable Care Act or not, it seems as if there has been an increasing consolidation in the healthcare marketplace. Hospital systems continue to merge, creating fewer options for patients. Whether this leads to improved care remains to be seen. Furthermore, while care can often be delivered more efficiently and cost-effectively in the outpatient settings, hospitals and insurance companies are able to use their legislative leverage to limit competition in this healthcare area. I believe that continued commitment to quality patient care will allow our specialty to flourish in the era of healthcare reform. Change is inherent in our field. In fact, it is what we do. As such, we must continue to innovate, but not simply in the clinical arena, but also in terms of healthcare delivery models.